My topic for discussion is little away from what we have been discussing since morning, optimizing heart failure therapy simultaneously with speed. And we all of us know heart failure has become a major issue in most of the places, more so in India. I think the data from Trivandrum Heart Failure Registry, although it's limited, has shown extremely important to treat heart failure very aggressively. We don't have any other disease right now has such a high morbidity and mortality other than maybe lung cancer. So heart failure is as deadly as lung cancer, I should say. So heart failure is growing to be a major health problem. And if you look at a lot of other things have changed. We could achieve a lot of improvement in cardiovascular disease, ischemic heart disease as a whole, stroke. But there are two areas where there are a lot of efforts still needed. One is heart failure, other is arrhythmias, what we are discussing since morning. So we all know heart failure is a very insidious disease. It starts before the patient becomes symptomatic. You know the stage A and stage B of heart failure is already there before patient present to you with any symptoms. So you have to be really aggressive to treat heart failure to prevent mortality and morbidity. So this is, if you see, look at how we diagnose. Close to around 62% of the patients are only diagnosed at outpatient. That clearly shows we are missing a lot. A disease like heart failure should have a majority of diagnosis happening at the outpatient level. But we diagnose most of the patients at acute critical care level at around 40%. So we know also that there is a close association between heart and kidney. So the patients who have a low perfusion secondary to heart failure tend to have more of a kidney damage, which may take away a lot of treatment options available for heart failure management. So here came another drug. We know one drug which has done extremely well. I think Dr. Abraham Momin sir has already highlighted ARNI. So we had, I think, after a long time, a drug which has shown excellent benefit in managing heart failure. I would say it initiated and brought back a lot of interest in managing heart failure patients. I have my personal experiences on patients who have been referred for transplant, has been treated with ARNI with a ejection fraction coming up to 40-45%. So guideline directed medical therapy, although is there for a longer time, so I think ARNI, I would say, has brought in a lot of light on this guideline directed medical therapy. Now we have gotten another drug, SGLT inhibitors, which has shown extremely good results in managing patients with heart failure. So DAPA heart failure is I would say it's another pioneer study where they looked at DAPA along with placebo. What you see in this patients is all these patients who have been started on DAPA were on guideline directed medical therapy. So DAPA was added over and above guideline directed medical therapy. So they looked at endpoints, a significant reduction in composite endpoint of cardiovascular death and worsening of heart failure in a range of around 26%. And cardiovascular death reduction was around 18% relative risk reduction with heart failure hospitalization around 30%. So extremely good results for a drug which is started over and above guideline directed medical therapy. This benefit was consistent across type 2 diabetes mellitus present or not, the patient had a background heart failure therapy or not, the diuretic dose and usage, baseline LV ejection fraction, NT-proBNP levels and EGFR. It reduced both first onset of heart failure related hospitalization and recurrent hospitalization for heart failure. It also had a reduction in all-cause mortality. The heart failure symptom improvement was more common and deterioration was less common. So there was significantly reduced risk of cardiovascular death and worsening as early as 28 days. This was the one drug which has changed the way we looked at heart failure management, I would say. I already told you, ARNI was the first drug which brought us to this medical management of heart failure to limelight. I would say this is a second drug, DAPA, which brought us to a lot of new thinking process in management of heart failure. Because this is the one drug among all guideline directed medical therapy which could bring about changes in risk reduction as early as 4 weeks. It's pretty unusual for you to see this early reduction in heart failure related deaths. To keep you in context, I would say that beta blocker trials, taking from Copernicus to CEPS, they all you have to put beta blocker for close to 3 months to achieve a clinical benefit. But DAPA was the first drug which could see the benefits starting from 14 days, and you could see the significant difference was seen at 28 days. And another good thing about this drug was it was well tolerated, even on patients without diabetes mellitus. Hardly any patient had adverse events to discontinue the drug. There was no major hyperglycemia, DKA secondary in patients who didn't even have diabetes mellitus. So it's a pretty safe drug. So benefit of, if you look at the patients who had receiving at 8 months, you could see a significant improvement in patients who are on DAPA and the quality of life questionnaire. So DAPA, what you should see, as I already told you, in DAPA heart failure trial, these patients were already on guideline-directed medical therapy. Although one thing I have to tell you that usage of ARNI was limited, even this DAPA heart failure trial. So the patients were already on ACE, ARB and beta blocker. They could see on an exploratory post-hoc analysis, the primary endpoint was around 34% reduction even on patients who were on ACE inhibitor. ACE inhibitor we know as a standard of care. As I already told you, the number of patients who were on ARNI was less even in the study. So I would say it gives you another point to believe that if the patients were on ARNI also, you would have seen much better results with the combination of the drugs. So when you look at the key subgroup analysis, the patients, whatever may be the etiology, the blood pressure levels, diabetic status or background heart failure therapy, baseline EF or diuretic therapy, all these patients had a significant improvement in the heart failure related endpoints. So other thing to be noted, we know there's the same 20% reduction in sudden cardiac death and ventricular arrhythmia was again shown in ARNI. This is another drug which has shown that composite ventricular arrhythmia, resuscitated cardiac arrest and sudden cardiac death was dropped by 21% relative risk reduction could be seen in DAPA also. So DAPA was well tolerated even with patients who are not on diabetes. So another drug, Emperor reduced, was a second large study on SGLT inhibitor and EMPA. So these patients also had a significant improvement. There are some minimal differences between these two drugs, but I would not go on to compare these two because the study population of these two trials were much different. Emperor heart failure has used a lot of sick patients, so you tend to see some differences between DAPA and Emperor. So looking at the data, we all know that we have to introduce this drug in clinical practice. How we are going to add this drug? The patients with management of heart failure with reduced ejection fraction has changed a lot. Now we have drugs which we call as a pillars of management of heart failure. It is ACE, ARNI. I would say any patient who can tolerate ARNI should be the drug. Beta blockers, myocardial receptor antagonist and DAPA or EMPA. So any patients with heart failure should be on all these 4 drugs to start with, and you can give loop diuretics or diuretics as per the symptoms. The same patient, in spite of all these drugs, if ejection fraction is less than 35% and QRS with this 130 seconds or less, if it is a ischemic heart disease, I would say that ICD is a class 1 indication. Non-ischemic, yes, still it can be used, it's a class 2A. If the patient has ejection fraction less than 35% and QRS with this more than 130 milliseconds, if you can further substantiate the statement, if the patient has a QRS with more than 150 milliseconds, CRT becomes a class 1 indication, while between 130 and 149, it's a class 2A indication. So if the patient is still symptomatic, even on these drugs, you can consider adding other drugs which are class 2A, like you have your other vasodilators, and ivabradine is used on patients who have a heart rate more than 70, even with beta blockers. You have add-on drugs over and above these drugs. But these 4 drugs has to be there on every patient. So to look at how we are going to use these drugs. So the patients, the usual way we titrate these drugs are we add one by one. we up titrate, reach a reasonable dose of a first drug, then add second drug. The problem with this strategy is a lot of time you may not be able to add all the drugs at the same time, or it may take reasonably longer time. So another important thing to look at here is we have a drug, SGLT inhibitor, which has shown very early benefit. So I would say that you may not have to wait for other drugs to reach the target levels before putting SGLT inhibitors in. So this is the conventional way of managing a heart failure with reduced ejection fraction. You first step add ACE or ARB, then you go to beta blocker. If patient is still symptomatic, you are go on to add MRA. And if the patient is not doing well even with these three drugs, you consider changing over to ARNI instead of ACE or ARB. Then you can consider a SGLT inhibitor. This stepwise approach is not acceptable for reasons I am going to tell you now. So this results in an unnecessary delay in starting therapies, and you may take somewhere between 6 to 8 weeks to titrate these drugs. All the 4 drugs may be in by around 2 to 3 months time. So the problem is adding these drugs one by one, you may end up in causing more complications also. Like you go on adding ARNI to a up titrating doses, you may end up creating an environment where you may have caused a rise in creatinine or rising potassium levels where you may not be able to add an MRA. Or you would have reached a level of beta blockers to such a level that the pressures are on the lower side, you are not able to add an ARNI. So to avoid all this, what we consider is you can do what is called a simultaneous addition or starting of these drugs. You can do this within 4 weeks. So what you can do is you can do this within 4 weeks with all 4 therapies so that the benefits can be seen early. So you add drugs which yields greater benefits than dose titration of other agents. So morbidity and mortality reduction can be seen even with low doses to start with. You don't have to reach the full dose to see the full mortality and morbidity benefit. So the magnitude of treatment benefit of each class is independent of background of what you are treating with. So the ARNI doesn't require that the patient has to be on beta blocker, or SGLT inhibitor does not require that the patient has to be on ARNI. So each have their own area of action and each can derive you benefit if they added alone also. So what you can do is, depending on patient's volume status, you can consider adding a beta blocker and SGLT inhibitor to start with. And when you are on a reasonably good dose, within a week or 2, add an ARNI. And if the patient renal functions are pretty good and your potassium is within the range, you can consider adding an MRA. The advantage with what we have seen with SGLT inhibitors is it gives you an environment for other drugs to act in. SGLT inhibitors have clearly shown that the patients who are on SGLT inhibitors tend to have a lower potassium levels when they are treated with other drugs which are going to give you hyperkalemia. And second, the level of hypotension seen with SGLT inhibitors are much lesser compared with other drugs. So you can create an environment for other drugs to come in. When you start a beta blocker and SGLT inhibitor, you may get a patient with a reasonably good creatinine levels and potassium levels to start on an ARNI. So that's the reason 2021 ESC and heart failure consensus statement considers starting SGLT inhibitors as a component of a foundational therapy for all heart failure with reduced ejection fraction phenotype. Irrespective of the phenotype, you can add. So if you look at this complete graph, there is no place where you cannot start a SGLT inhibitor. I would say except that a severe renal dysfunction where your GFR is less than 20. That's one place where you may not be able to add any drug other than beta blocker. So this is on real world evidence. What happened to the patients with DAPA and what will be the ideal candidates. So if you look at the overall data, so it shows that it significantly improves heart failure related endpoints even on patients who have been on full foundational therapy for heart failure. So this looked at, when you look at this data, you can see here, I'll say. So you can consider SGLT inhibitors in most of the patients who present with heart failure. So if you look at patients, you select a patient with reduced ejection fraction. So you can start a dose. We know very well the DAPA, biggest advantage is a single dose. You don't need any big titration, and it's a once a daily. The only place you have to be a little careful is when GFR goes below 20, and you can start this drug even on outpatient clinic. You need not admit the patients. So only there are few initiation considerations. You have to look at the volume status. Try to bring the patients as euvolemic as possible. So you have to check the patient's renal function periodically. If the patient has diabetes, you have to always keep in mind the risk of DKA. So when you prescribe DAPA, I would say that the one thing you have to be very much, I do in most of my patients, to talk about genitourinary hygiene and to report to you when the patient develops symptoms related to genitourinary infections. You can follow these patients closely, and most of the patients tolerate pretty well. And I think this is one drug on heart failure therapy which is tolerated reasonably well. So that we know very well that most of the patients, even what Dr. Abraham was telling, that we know very well these 4 pillars of treatment has to be on every patient with heart failure. But unfortunately, not all of our patients with heart failure is on guideline-directed medical therapy. So the first thing we have to see and implement is all the patients with heart failure should be started on all the 4 drugs which have been shown to be beneficial in reduction of mortality and morbidity. And one way to initiate this is you can initiate them simultaneously. That's the one way you can get this drug very early and treating these patients with heart failure. So in this time, I'll just skip few slides. So this is how your post-discharge for any patients who have had a heart failure admission should be there. So RNA, we know we have a lot of studies which have shown that in hospital initiation of RNA has a lot of benefits. Beta blockers, as and when your patient becomes clinically stable with congestive heart failure, beta blockers can be initiated. You can titrate them every 2 to 4 weeks. And MRA, if the patient is on melanocorticoid receptor antagonist, only thing we have to look at is potassium levels, particularly you are co-prescribing RNA. SGLT inhibitors, you have to start the patients as early as possible. Now we have a data where pre-hospital, pre-discharge starting up both SGLT inhibitors and RNA have a beneficial value. With this, I'll close my talk, and we can take questions on heart failure together. Thank you.